Welcome, everyone. We're going to be talking about chronic migraine with Dr. Elspeth Hutton. Essentially, our mission is threefold: to provide trustworthy and reliable information. Often, the information articles on our website are medically reviewed by neurologists and headache experts. To fund research, and we try to do at least one research project into migraine and headache each year, and to advocate and support people living with migraine and headache disease. And we do that through a number of different ways. And just to highlight some of the things that we've been doing in the last 6 months. We spoke about one of the images last night, and each evening, each session, we're going to be highlighting an image or two that's on that's on this screen, just to sort of talk about some of the work and activities that we've been doing. So tonight, we're going to be talking about these two images, and you may recognize. I'll give you a chance to put in the chat if you recognize any of these individuals, apart from myself and Trevor, who is our CEO, who's in the blue striped blazer. Does anyone know who? And I'll give you a clue. They are both senators. But feel free to jump in the comments if you recognize who they are, if you're particularly politically astute. I'll tell you who the first one is. In the white jacket on the left is Anne Ruston. That is correct, Colleen. You got there just before I did, so I know you didn't cheat. Well done. She is the Shadow Minister of Health. So she's the Minister of Health for the Liberal government in the federal political, I'm sorry, what I call it, MPs. And we've met with her and her team on a number of occasions to talk about migraine and the impact of migraine, particularly on women, but also in the general population on men. And also her staff. And the other senator that we have in the photo on the top right-hand corner, or towards the top right-hand corner, is Senator Wendy Askew from Tasmania. And we've also spoken to her about the issues of migraine in the workplace, as well as migraine and the impact of migraine on Australians, and the rationale to take action and to do something about it. And there's a number of different ways that we've been sort of speaking and developing those relationships. And this is something that we do as part of the Brain Foundation. We don't have someone full-time in Canberra like some of the other large nonprofits do. That would be amazing. But with the resources we do have, we do try to get down to Canberra multiple times. You can see there's photos of us in front of the Parliament House in the grey background here. And it's one of the things that we've been doing lately in the last 6 months. One of the other things that I'll highlight is the advocacy toolkit, and many of us would like to, and I'm not saying that this is for everyone, but some of us would like to actually speak to a policymaker or a journalist and tell our story, and we have opportunities to do that. We've had opportunities to do that this week during the Awareness Week, and we often have opportunities to do that when there's new news or there's breaking news or a new treatment. And so there's ways that you can get involved. And we've put together a short video that highlights some of those opportunities and a toolkit for you to be able to reach out to your local MP, which is actually a lot easier than you think once you know what to expect and how others are doing it themselves. And it's just to have a conversation about your situation, your experience with migraine, and how it affects you. And that can be really illuminating to an MP, particularly when you're in their electorate. It's actually a lot easier than you think to have meetings with your MP. Many of them will take those meetings. And so that's an opportunity for those people who are interested. We'd encourage you to check out the website, that URL below. And we can provide that URL in the chat if I'm moving too quickly. I'd like to thank our event sponsors, AbbVie, the Brain Foundation, Pfizer, and Lundbeck. Their support has helped us have a greater reach and impact, and we're very grateful for their support. Now, if you're wondering, am I in the right spot? I wasn't here last night. This is the first time I've connected. If you want to learn about chronic migraine, if you have migraine or headache or a recurring headache disorder, you're in the right place. If you're a partner, parent, or caregiver, if you want to connect with others, we have the chat open. We'd encourage you to engage with other people as well as listen to our expert. That's part of the value of joining. And especially if you'd like to ask a question, you're in the right spot. We also have a support group on Facebook. We recognize Facebook's not a perfect tool and not everyone loves Facebook. the infrastructure that Facebook provides makes having a support group quite effective. So if you are on Facebook and you're part of other groups and you're interested in joining, you are more than welcome to join. There is no charge. It is free. And it is a great place to connect with other people living with migraine. It's not a place necessarily full of doctors, but we try to keep it promotionally free and a useful conversation for people that are living and working with migraine. So, with that, we'll introduce our speaker for tonight, Dr. Elspeth Hutton. She is a leading headache specialist in Australia. She's the president of the Australian and New Zealand Headache Society. That's the peak medical body in Australia and New Zealand for migraine and headache. She works at the Alfred Hospital, and she established the diagnostic and clinical service in neuropathy, neuropathic pain, and headache. You couldn't ask for a more perfect person to cover tonight's topic. So throw her your most challenging questions. She's probably listening and thinking, "Oh, Carl, thank you. No, not necessary." Um, she's also a researcher at Monash University. She is an award-winning neurologist and headache specialist who's been recognized internationally for her work in pain, diagnosis, and management of neuropathy, pain, headache, and migraine. So it's my pleasure to bring her to you tonight. And I'll very quickly just introduce Anik Grundy. She's our moderator tonight, along with Vanessa Mundell, who is also going to be in our comments. So if you have questions, you might see answers and responses from them. Anik has been behind a lot of the fantastic content and information and articles that get medically reviewed on our website. And she manages a lot of the programs, the grants, and is our digital lead. So very warm welcome and a very big thank you to Anik and Vanessa for the work they've done to bring this Headache Week together. And something I didn't do last night that I probably should do is introduce myself. I take for granted a lot of you know who I am, but some of you who are new, perhaps maybe not. And my name's Carl Cincinnati. I'm the lead for Migraine and Headache Australia. I live with migraine myself. I used to be chronic, and fortunately, I'm episodic these days. And I wear a couple of different hats in the migraine and headache space, but I'm all in on this topic. It's something I'm very passionate about, and I've spoken nationally and internationally about the need for greater funding, more support, and advocacy for people living with headache and migraine. So with that, Dr. Elspeth Hutton.
Thank you everyone for joining this talk on chronic migraine, and thank you to the Brain Foundation for organising this fantastic series of talks. I'm going to cover a range of things today, a little bit about the background of chronic migraine and how it impacts people, and then talking about the biology of it and which treatments are effective and how it's best managed. So chronic migraine is a subset of migraine, with migraine being a recurrent, complex, disabling neurological disorder. Migraine affects about 20% of the population and is 3 times more common in women. And chronic migraine is estimated to affect about 2% of the population. And in Australia, that's about 500,000 people. There's a greater impact on socioeconomic functioning and quality of life. And there are estimates that less than 20% of those with chronic migraine have actually been diagnosed. So it's a huge area of unmet need in the health system. Chronic migraine is defined by the International Headache Society as more than 15 headache days per month for more than 3 months, of which 8 of those days have migraine features, which include nausea, sensory sensitivity, such as sensitivity to light or noise, and functional impairment, so they're headaches that limit what people can do. They can't go about their normal day unaffected. When comparing chronic migraine to other primary headaches, there are a number of features that are useful to consider. So the 4 headache types that we think about mainly are chronic migraine, chronic tension type headache, new daily persistent headache, and hemicrania continua. So distinguishing these other types from migraine, a tension type headache is usually a bilateral, tight pressure sort of a headache, and it doesn't have as much in the way of associated features. So unlike migraine that will have nausea, vomiting, hypersensitivity to light or noise or odours, and being worse with physical activity, in tension headache, there might be a little bit of light or noise sensitivity or some mild nausea, but generally they're far less prominent features. New daily persistent headache is not as defined a phenotype. So it can present similar to migraine or similar to tension type headache. But the characteristic of this headache is that it's unremitting within 24 hours of a clearly remembered onset. So it's a continuous headache where people will say, on the 22nd of October, I started getting this headache and it hasn't gone away since. Hemicrania continua, on the other hand, is a one-sided headache. It's aching in quality and is continuous. And it may have either those migrainous features of sensory sensitivity and nausea or autonomic symptoms with exacerbation. So people may get tearing or redness or grittiness of the eye on the affected side, or flushing of their face, ringing in the ears or fullness in the ears. And those headaches are characterized by being 100% responsive to an adequate dose of indomethacin. So people might be advised to do what we call an indomethacin test to clarify that diagnosis. Screening for secondary headaches, where the headache is due to another problem in the brain or another metabolic problem, is always important to consider, but it's certainly less likely in people who come in with a history of having episodic headaches for some time that are gradually increased in frequency and transformed to a chronic headache. One thing that I just want to flag to people is that there are some common misdiagnoses of chronic migraine, and probably the commonest is sinus headache. A primary care study in the US looked at about 3,000 people with what they thought was sinus headache coming to the GP and being reviewed by a sort of headache neurologist. And of those people, about 80% of the people who thought they had sinus headache actually were reclassified as migraine. The reason it can be a bit confusing is that both headaches can give you pain in the midface and nasal congestion, and that can lead to misinterpretation. When you consider chronic rhinosinusitis, true headache is really rare with that condition. People can get a dull pressure sensation worse in the morning and with some associated nasal drainage and obstruction, but they usually won't have nausea or sensitivity to light and noise, and it'll usually be eased with decongestants or sort of nasal topical local anesthetics. So moving on to the biology of migraine, people will probably have seen this graph in a few iterations that looks at the evolution of a migraine attack, that migraine is more than just the period of headache itself, but will actually have dysfunction in the brain and associated symptoms that can start 2 hours to 2 days before the headache. And people can have continued symptoms and changes in brain function for hours to days after the headache. I often talk to patients about migraine threshold, and that the problem with migraine is that you have a threshold to attacks that means the attacks trigger more easily than in someone who doesn't have migraine. In normal people, there are networks in the brain that oscillate and kind of drive sensitivity to stimuli on a regular basis. But in people with migraine, that oscillation is disturbed. And so you can consider it as a periodic sensory dysregulation arising from those changes in brain threshold. The thresholds can affect the sensitivity to light, sound, touch. They can also affect mood and cognitive function. And the goal of treatment in migraine overall, but particularly in chronic migraine, is to increase the threshold for an attack so that the attacks aren't triggered as readily. Looking at chronic migraine in terms of what makes people prone to it and what protects people from developing it, there's very much a concept of this decreased threshold for the generation of migraine attacks, and part of that threshold is a hereditary aspect. So people inherit a combination of gene polymorphisms that make them more likely to have a lower threshold to attack. But people who have other factors, such as women, obesity, depression, stressful life events, they will all make people more likely to develop chronic migraine. There are a number of protective factors. So people who have appropriate, effective, early institution of a preventative medication will be less likely to develop chronic migraine. People who use acute medications appropriately, so they have effective treatment that works well and aborts the attack, but balanced against not using those treatments too often. Having good social supports tends to be protective. Regular exercise and regular stress management tends to be protective. So there are some of these factors that we can modify and some of them that we can't, and we need to consider all of these things when we're managing people with chronic migraine. So what changes from the patient perspective when you develop chronic migraine? There'll be obviously an increased frequency of migraine attacks. And then over time, there tends to be a reduction in completely headache-free days, what we call crystal clear days. So there's this evolution of a background headache with flares of migraine on top of that. It can become much harder for people to clearly identify the onset of a migraine attack or a flare on that background, which often makes it harder for them to choose when to use their acute medication. And they often find their acute medication becomes less effective, so it doesn't work as well for them. And that combination, coupled with increasing anxiety about increasing attacks, often will push people into that medication overuse spectrum. And people often talk about kind of worrying about an attack and taking things in anticipation. There's a development of what we call allodynia, which is sensitivity to stimuli that shouldn't be painful. So people will describe their scalp being sore. It'll hurt to brush their hair. It'll hurt to lie on the pillow at night. And that allodynia is involved in a process called central sensitization, where the networks in the brain involved in pain processing and migraine in particular have a change in their balance between inhibition and activation. The migraine-specific features are often less prominent, so the nausea and light noise sensitivity tend to become a little bit less distinct, but often a little bit more kind of pervasive all the time. And the evolution from episodic to chronic migraine is also linked to lower mood, obesity, sleep disorders, and these are probably bidirectional effects. So these things are certainly a risk for developing chronic migraine, but it's very sort of easy conceptually to understand that if you have chronic migraine, you're more likely to develop these conditions. And there are neurobiological reasons behind that in terms of shared function of some of these networks. It is a reversible condition. So the increasing morbidity and comorbidity is one of the sort of key reasons over and above living with pain all the time, that it's really important that these conditions are treated appropriately. The traditional classification of migraine has been between episodic and chronic, but there's an emerging discussion around the idea of a new category called high-frequency episodic migraine, which is 8 to 14 days a month of headache. And the rationale behind that is that the burden of disability and the impact of headache at that frequency is actually pretty similar to chronic migraine. So why do people develop chronic migraine? And it's very hard to simplify sort of migraine biology into easy figures, but I think this is a great figure from Edvinson's paper of 2019 that goes through the systems in the brain involved in migraine. So in a migraine attack, the originator of the attack are areas deep in the brainstem and the hypothalamus that then activate a series of circuits around the trigeminal nerve being active and other centers in the brain being involved. Moving on to how that process evolves into chronic migraine, you draw in this concept of central sensitization. So again, the initial sort of stimulus to the migraine attack relates to hypothalamic activity, and the initial phase will be that peripheral sensitization, so sensitization of the trigeminal system. And the characteristic of pain at that phase is the throbbing migraine pain that people are very familiar with an acute attack, sensitivity to their pulse, sensitivity to exertion, and that relates to the movement of blood vessels within the dura. If you have frequent stimulation of that system, you then have ongoing increased activation of the trigeminal nucleus, and that level of processing becomes sensitized, which will then connect to the neurons in the thalamus and the other circuits in the brain, and they become sensitized. So you have this evolution from kind of pain just when you have an attack to more sort of cranial allodynia, that sensitivity to touch, to actually, in some people, the development of more widespread allodynia and that persistence of other sensory sensitivities. And the thalamus also connects to what we call the limbic system, and that process is involved in regulation of memory and cognition and emotion. So again, coming back to that evolution of depression with chronic migraine, you can see how these things are linked on a neurobiological level. So what evidence do we have that the migraine brain is different to in chronic migraine to episodic migraine? So there are certainly a number of imaging studies, and it's useful to think about this concept of the pain matrix, which involves a number of centers in the brain that regulate different aspects of pain perception. So the kind of, what hurts, where does it hurt, how badly does it hurt? Also the emotional aspects. How do I feel about it hurting? Am I scared about it hurting? Is it making me feel more anxious? And they're all sort of in that matrix. And then there's a secondary system that's a descending regulation of pain system that is basically okay, you've told us it hurts, but now settle down and don't keep telling us it hurts. And both of those systems are disturbed in chronic migraine. So there's greater activation of the pain-inducing processing regions. There's altered connectivity of the default salience and central executive networks. And that's also interesting. One common feature of people when they have an acute migraine attack is when they're not in a migraine attack, they know very well that when they get a migraine attack, they've got a plan to take their medication early and have certain behaviors. But when they're actually in a migraine attack, their ability to execute that plan tends to go a little bit sideways, and that may relate to those executive networks not working so well. There is some reversibility of these things reported. So it's not my brain has changed and it's always going to be different. More information and more research is certainly needed in this area, but it underpins the idea that this is a very real neurobiological disease with neurobiological consequences if it's not managed well and evolves into chronic migraine. In terms of doing blood tests or looking at CSF to identify when people have chronic migraine versus episodic migraine, the field is very new and it's certainly not at the level where you can go and get a test for it at your GP. But there certainly are certain neurotransmitters and compounds that are increased in chronic migraine in the CSF. So glutamate, which is an excitatory neurotransmitter, CGRP, which we know is one of the key transmitters in migraine, nerve growth factor, which has very pleomorphic effects, but is involved in kind of inflammatory change and neuroinflammation as well, and beta endorphin, which is reduced, which is the body's anti-nociception system also being impacted. So I tried to summarize all the factors that go into evolution for chronic migraine. It's quite a hard thing to summarize in one slide, but fundamentally we have a threshold disorder of sensory regulation with associated metaboloendocrine and neuroinflammatory dysfunction, and also reduced cerebral energy reserve. That in conjunction with risk factors such as high baseline attack frequency, overuse of medication, the being female and having stressful life events, genetic predisposition, obesity, depression, sleep disorders, all pushes people towards that evolution to chronic migraine with protective features that can modify some of those factors, such as exercise, stress management, reducing caffeine, having good sleep habits, eating regularly, effective acute and preventative therapy. And management of comorbid conditions is also important. The net effect of all of this is the evolution of central sensitization, a more excitable brain, impaired descending inhibitory control, the DNIC system, and it's that system that the Navivio device for treatment of acute migraine works on, that you put on the arm and it stimulates pain fibers to activate that system. And the flow-on effects in several of the thalamic networks connecting with the cortex, the limbic region, and also hypothalamic dysfunction. When I'm seeing somebody who's having an increased frequency of migraine days or headache days, I always kind of go through a thought process about, are they overusing their acute medications? Has there been a recent hormonal change, particularly perimenopause in women? Are they having problems with sleep? Has there been a metabolic shift? Have they developed diabetes or hypothyroidism? Is there actually a secondary headache phenotype? So people can have more than one type of primary headache. And if you lump everything under the same initial classification, you can sometimes miss the evolution of another problem. So touching briefly on medication overuse headache, medication overuse is a really important aspect of managing migraine, and particularly more frequent migraine and chronic migraine. This is a worsening of the underlying primary headache, which is usually migraine in about 80% of cases, linked to the overuse of acute aborting medication. Medication overuse headache can mask some of the more migraine-specific features of the underlying headache, and it won't occur in everybody who overuses acute medications. So it's a biological risk, and it's a risk that we see being present in a lot of patients with migraine, but it's not a 100%. There's a higher risk of developing those changes in people who overuse opiates or triptans. And again, comorbid pain conditions, and again, smoking and physical inactivity increase risk. The underlying biology of medication overuse headache, we know that in these conditions, there's structural, functional, and metabolic changes in these central pain networks, and particularly alteration of serotonergic and endocannabinoid signaling, with the net effect of increasing neuronal hyperexcitability and central sensitization, and reduction of that descending neural inhibitory control and conditioned pain modulation. What do we do about it? Certainly withdrawing the acute medication is core to this. It's important for people to know that if you stop an acute medication you've been using too often, your headache may get worse before it gets better. And the timeline for that is about 3 to 7 days for triptans, but it's about 3 to 4 weeks for opiate medication, including things like codeine, which is one of the reasons why headache neurologists are particularly nervous about any opiate use in people with migraine. So the overall limit for acute analgesics would be about 10 days per month for triptans or opiates, or about 15 days a month for things like Panadol or ibuprofen. The recent guideline from the International Headache Society actually suggests kind of limiting everything to about 10 days a month, which is probably sensible. It means if you go over it a little bit every now and then, it's not the end of the world, but you've got that goal in mind. How do we help people through this process? Well, the options are, just withdrawing the acute medication and seeing what the impact on the headache is. And for some people, that will be very effective. But we will often look at adding in a preventative therapy to try and reduce the need to take the acute medication concurrently. Education and support are really important. Management of the comorbid pain conditions, and also any mental health issues. So people who have a lot of anxiety in particular that drives their medication overuse, it's going to be hard for them to stop taking the medication if we don't think about the anxiety as well. Sometimes it's worth thinking about bridging options. So things like greater occipital nerve blocks can often buy a period of stabilization of the underlying headache, which makes it easier to not use the acute medications. And really the goal is to get people through that period where the headache may get worse coming off the medications, so it's then easier to control their use moving forwards. So chronic migraine, as I said, does get better. It does revert back to an episodic migraine state. There have been a couple of studies that incorporated looking at how many people with chronic migraine reverted back to episodic migraine. The difficulty with interpreting them is that they didn't really take into account whether people were on preventers or what preventers they were on, but it's still reassuring data. So in the American study, there were about 26% of people who reverted over 2 years. And in the Cameo study, about half of patients reverted over 3-month follow-up. And again, it underpins the dynamic nature of the transition from chronic to episodic migraine and back again, and those changes in neural networks. There are a number of treatments that have shown to be useful in chronic migraine. So Botox reduced monthly headache days by about 9. The other table on this slide was looking at things in a slightly different way. So it was looking at the relative chance of a 50% reduction in monthly migraine days. And I've just highlighted in those orange boxes the medications that were more useful in achieving that. And certainly they're the sorts of medications that we would be thinking about starting in somebody who came in with chronic migraine, because you want something that's going to be more effective. So the goal is to get people on an effective, well-tolerated preventative. You always want to know what people have tried in the past and what response they had to them. Were they stopped because they gave them side effects, or were they stopped because they didn't work at all? Or were they stopped because they worked but not well enough? And ideally, what dose people got to, so you know whether it was kind of an adequate trial of that medication. The main thing I think about when starting a preventative is what else is going on for the patient. So you'll think about different options in somebody who has overweight and diabetes compared to somebody who is very anxious or depressed. Or if somebody has comorbid high blood pressure, then the antihypertensives are more attractive. So it's always useful to think about, can I get one medication to do more than one thing? And what medications are more likely to be useful for the other problems that are going on for that patient? The other thing that's really important to think about is the individual balance that people have between how well the drug works and what the chance of side effects of the drug are, because everybody has a very individual space that they sit on that spectrum. Some people want something that's really effective and really don't care if it gives them a few side effects if it works, whereas other people are really apprehensive about any side effects and will tolerate a potentially less effective medication to offset the lower risk of side effects. And it's, again, important to say that all the range of preventatives we have, there are individual people where all of those drugs work well. So although it's great having the more effective medications like Botox and the CGRP monoclonals, there are some people who will still do very well with the older oral medications for migraine. So if people really have problems with side effects, then obviously you stop it and you try something else, and trying a different class can sometimes be useful to try and avoid those side effects recurring. And if you kind of get to the end of that 12 weeks and it's worked to a degree, but not enough, then I would generally add in a second agent and see what people's response is to that before weaning the first one. Some people will actually do better with a lower dose of two partially effective agents than a higher dose of a single agent. So it's worth being flexible in approach for this. And certainly, again, given the high efficacy, considering Botox or CGRP monoclonals early, if there is a poor response to the oral agents, is important so that you give people the best chance of getting the headaches under control. And you need to try at least 3 oral agents for PBS rules to be eligible for these advanced therapies. But more broadly, non-pharmacological management still has an important role to play in the management of chronic migraine. And it comes back to that idea of the hypothalamus and the regulation of equilibrium in the body. And what I often tell patients is that the migraine brain doesn't like change, and that can be internal change or external factors that are causing change. So all of those lifestyle optimization things like sleep and hydration and diet and stress management and exercise, I think sometimes people feel it's a bit twee to be talking about that to people with chronic migraine, that, you know, they're in a really bad state and they need something more than that. And that's absolutely true, they do. But getting those fundamental bedrock issues right for people makes it much easier for the other medications to work well. And I think the key here is giving people personalised advice, so taking into account their particular situation and giving them specific tools to help them work on these lifestyle measures. So just telling people to do some stress management, it's not very helpful. You need to give people a kind of a suite of tools about what does that mean and how do I achieve it, and which of those tools is probably going to work best for me in my life. And the sort of supplement nutraceutical space, certainly there is evidence for magnesium, CoQ10 and B2 or riboflavin for being helpful in reducing frequency of migraine attacks. And there's a bit of emerging evidence for a compound called PEA as well, which has some activity through the endocannabinoid system in the brain. I always will also think about vitamin D deficiency and iron deficiency, particularly in women with menstrually related migraine for iron. And I've certainly seen patients who have destabilised really quickly with low iron levels that have improved really quickly when those have been replaced. Acute treatment, again, it's about tailoring the choice and the combination for optimal efficacy for the individual. And in the chronic migraine space, it's sometimes very difficult to find that balance between treating migraine attacks early but avoiding overuse. And this certainly becomes easier as we reduce the headache frequency with preventative medication. So the focus in the sort of initial phases of chronic migraine is often more on the lifestyle measures and preventative medication, and coming back to the acute medication a little bit later on when there's sort of more distinct attacks and it's easier to judge when to treat them. In terms of diet and caffeine, certainly caffeine used acutely, a lot of people will find helps abort a migraine attack, but used chronically, it acts the same way as other acute medications in that it will tend to make your headaches worse. Plus, it will have impacts on sleep if you're having it in the afternoon and the evening, so it can kind of disrupt your sleep architecture, make it harder to fall asleep, but also make that sleep less efficient. So the limit is generally about 2 cups of a caffeinated beverage in a day, whatever sort of caffeinated beverage people want to consume, as long as one drink isn't a coffee with 12 shots in it, so it's sort of per shot. In terms of diet, it really comes back to, again, keeping things even, so keeping people's blood sugar on an even keel so that highs and lows don't trigger migraine attacks. So eating regularly, avoiding really simple processed sugars, eating a range of fruit and vegetables and good quality protein, complex carbohydrates, so that, again, that sort of release of blood sugar is more of an even process, and lean protein. If people know they have particular triggers, it's useful to avoid them, but I would certainly avoid getting hung up on trying to cut out everything that might potentially be reported as a trigger for migraine. Triggers are an individual thing. If you know you have red wine and you get a migraine, then it makes sense to avoid red wine. But if you don't sort of have any obvious issues with things like citrus, then there's no need to avoid it. It's also worth thinking about specific strategies to manage sensory sensitivity in chronic migraine, particularly light, but also noise and balance disturbance. So there is data to support the blocking of blue wavelengths of light as being a helpful thing at reducing migraine attack frequency and severity. But it also can be helpful in just managing kind of background intolerance of bright light or intolerance of screens, the people who are very photophobic or find that sort of moving stimulus upsets them. Sometimes these sorts of filters can be quite helpful in helping with that. There's also data that green wavelengths of light can have an anti-nociceptive effect, so they can actually improve pain relief. So blue light filtering lenses, I guess, come in 2 flavors. There are ones that actually filter the blue wavelengths, which tend to be the amber or red colored lenses. And there's the sort of blue light filter that you'll get from your optometrist on normal glasses. That reduces the amount of blue light that gets through, but it doesn't block it as completely as the actual blue light filtering glasses will. So they're sort of questions of degree. Using natural light where possible is helpful. Looking at your screen settings is helpful. So changing sort of contrast and managing glare. So it's very obvious outside that sort of hats and sunglasses are helpful. But actually, for some people with migraine, particularly if they're in office environments and have a lot of fluorescent overhead lights, wearing a cap at work can actually be quite useful at reducing some of that sort of extraneous glare that tends to make things worse for them. Noise cancelling headphones, using sound reduction earbuds if you're not wanting to block things out completely can, again, just turn the volume down on the world around you. And for people who have a lot of balance and equilibrium issues, then certainly vestibular physiotherapy and balance exercises can be helpful too. So in summary, chronic migraine is a really significant problem with higher levels of morbidity, higher impacts on people's life, higher levels of disability, as well as increased risk of developing other conditions such as obesity, depression, sleep disorders. So it's really important that we treat this effectively. In an ideal world, you'd get people with migraine on a preventative early before they'd evolved into chronic migraine, but even in the chronic migraine state, you still want to get that into the treatment plan early in the piece. It needs to be a collaborative decision and very much individualised for the patient. You want to optimize acute treatment options. In chronic migraine, it's probably not going to be so much the initial focus because of the difficulties we discussed earlier, but it's certainly worth revisiting when people's headaches come down a little bit because they'll often find that they're more sensitive to the treatments then. Lifestyle measures are important in that concept of the migraine brain not liking change. But be kind to yourself. One bad day where you sort of fall off the wagon isn't a failure. You just go back the next day and try and do better. Gradual change is always best. So try and change one thing first and get that to stick before you try and change everything about your life, because that in itself will be a significant stress. Chronic migraine often feels different to episodic migraine. So there's much more of the pervasive fatigue and cognitive fog and sensory sensitivity. And people often worry about what that means, particularly in the cognitive space. It isn't usually actually a new problem that's causing these things. It's part of the change in biology of migraine as it becomes chronic, and it will usually improve as your migraine does. So stick with the plan and talk to your doctor about how to optimize your treatment, and I wish you very well. Thank you.
What an incredible presentation from Dr. Hutton. We're going to have some Q&A time. So Dr. Hutton, if you can join us for that, that would be fantastic. There was so many gems, so many very important and crucial bits of knowledge. I know a lot of people were saying in the audience, wow, can we get a copy of the slides? When will this recording be available? I feel like them, like as soon as we finish here, I feel like I need to go rewatch it again and be able to sort of pause and rewind and catch things. So thank you so much. That was such a critical presentation on such a challenging problem that so many of us face. For those of you that have put questions into the Q&A, thank you. We're going to start there with the questions. We did have a question about the NDIS, which we've responded to. But one of the first questions that has, interestingly, some of the most upvotes is a question from Lynn, which is about why migraine may start between 3 and 6 a.m. in the morning.
Yeah, it is an interesting question. There are a lot of regulatory processes that go on in the body, and the day-night cycle is key to that regulation. So as the light changes over the course of the day, as it gets towards the evening, your body starts to produce more melatonin, which is the cue for you to go to sleep. And then you sleep, and during sleep, there are a lot of changes in sort of hormone levels, in clearance of sort of waste products from the brain, in sort of memory consolidation and recovery of the brain. So again, it comes back to the hypothalamus, and the hypothalamus driving a lot of the other centers that are involved in the genesis of a migraine attack. There was an interesting data presented at the Migraine Trust meeting last week, actually looking at the peak time for migraine onset, and it was around kind of midnight. So that sort of early hours of the morning was key. And interestingly, in a slab of time, kind of just before that, sort of the 4 hours or so before that, there were peak levels of CGRP in the body. So there are very strong sort of biological underpinnings that underlie that tendency for migraine to be in the early morning. And that comes back to why we keep harping on about why it's important to have regular sleep habits and try and keep that cycle even. But it also has interesting implications for the timing of when you give preventative medication and whether that can actually be leveraged to give the peak effect of the medication when you have the peak vulnerability to the attack.
Interesting. And when you have a migraine in the middle of the night that wakes you up, it's going to wake you up typically in pretty full force. You don't have a lot of time to get in a Triptan early in that situation. What do you advise your patients to do in that situation?
Yeah, no, it is tricky, and they are often the hardest ones to turn off. The first thing I say is make sure you've actually got your drugs by the bedside and some water by your bedside. So if you do wake up, you can just take it. And again, it's a combination of the being a bit befuddled when you wake up at 3 o'clock in the morning, plus that factor of when people have a migraine, they're often a bit less kind of good at actually enacting the plan that they had for when they get a migraine. So if it's sitting there next to you, it's easier to do. But the other aspect is being very aware of how you felt the night before, because often when people have those early morning migraines, they actually went to bed feeling not quite right and were starting to get a bit headachy. And in that context, sometimes things like using a slow release anti-inflammatory at night can also be a helpful strategy. So that's where diaries are really important, to tease apart the symptoms and tease apart the typical pattern that somebody gets so that you can really target the therapy appropriately for them.
Anna had a question, and she asked, are people with migraine more likely to develop dementia?
Yeah, that's a question that comes up a lot. The short answer is no, not on the data that we have thus far. Um, a lot of it comes back to the sort of white dots that turn up on scans and what do they mean. The data we have doesn't suggest that people have an increased risk of dementia, but I think it's really important for everybody, but particularly, people with migraine, and particularly if they are developing any of the other comorbidities, sort of obesity and other metabolic issues over time, that people are up to date with screening for things like cholesterol levels and diabetes and blood pressure, and all of those factors are actively managed. And having an active, healthy lifestyle is, again, one of the best preventions you can have against developing dementia.
Does your brain just get so used to pain that it forgets to turn itself off? We had someone that said that I've reduced my stress and my triggers, but the pain in my migraine eye just won't go away.
Yeah, I mean, in a sense, that's what some of that sort of data about the neuroimaging changes and the network changes comes back to. When you keep reinforcing a circuit, it's not just the sort of trigeminal circuit that is active. You then have secondary changes higher up the tree in the sort of the ultimate arbiter of pain, as it were, rather than just the peripheral trigger. But equally, if you can stabilize migraine for a time, you can start to unwind some of those changes and get back to not having pain. So I think, again, it comes back to continuing to hunt to get a preventer that works to consolidate all of those lifestyle factors so that you've got the optimal chance of improving things.
Can people apply for disability funds if they have chronic migraine and can't work?
Yeah, that's a question close to my heart. The short answer is yes, if you have a disability, you can apply for disability funds. The long answer is it is a difficult journey for a lot of people to actually get disability support for migraine, particularly without kind of other comorbidities. And it's something that I really think we need discussions with the government about how migraine is recognised in the disability space. The UK has got some very straightforward guidelines that's basically, if you can't do your job for more than a certain number of days a month, then you have disability. Our guidelines are sort of tied down in lots of tables and specific sort of point gathering, which I don't think actually works very well for the majority of people with migraine.
Yeah, agree. And I know that you've been vocal and you've written to the government about exactly this issue, and appreciate your advocacy on our behalf. So thank
You're
you.
very welcome.
Another question was the link between chronic migraine and trauma. So, for example, PTSD.
Mm.
What is the link there?
Yeah, I think, again, it comes back to all of these interconnected networks, and that a lot of the systems that are involved in the pain network are also involved in sort of trauma and flashbacks and memories of trauma, plus the impact on mood and sleep and sort of stress and inflammatory levels in the body. So it's a really complex network. And that's where I think it's really important when you're looking after people with chronic migraine that you don't just see the migraine in a box by itself. You see all the other things that are going on for that patient and try and address as many of those aspects as possible. It can be difficult, I think, for people to get really good care for complex trauma in the public health system in particular. And that's something, again, that I think we need to keep advocating for better integrated care, because there are medications that we use in migraine that can also be beneficial in that space. But you really need multidisciplinary input. So it's beyond just the medication aspect. You need more of the therapeutic aspect as well. So I think, we need to keep trying to do better in how we manage people with complex overlap of conditions because it's really important to address all of them.
Tani had a question that Leela and Crystal both chimed in on regarding heat and sun and how that causes migraine attacks. What's happening there?
Yeah, so light and day-night cycles, obviously the brain is designed to process information from the environment and respond to it appropriately. And when light enters your eyes, there are a variety of pathways in the brain that it activates beyond the simple I see a square in front of me pathway. And some of those connect through the hypothalamus and the thalamus and then activate other areas of the brain. And if you think back to those sort of lovely complicated anatomy diagrams of migraine biology, the hypothalamus and the thalamus are two very key areas in the genesis of a migraine attack. So it will alter the sort of stimulus suppression networks that are coming out of those nuclei to be exposed to light or not exposed to light. So there are sort of changes in whether the system is activated or suppressed that are governed by light.
And does the same principle apply to heat?
Yeah, heat's probably a bit more complex, and it's probably the type of heat and what you're doing. So certainly when you're running around on a hot day, you tend to get more tired, you tend to get a bit dehydrated, there tends to be glare involved. It's a metabolic stress on the body. And again, it's that sense of people with migraine not liking any change in the equilibrium of normal. And heat is certainly something that changes that equilibrium of normal. So it can certainly trigger it. Not going out in the heat of the day, keeping yourself well hydrated, avoiding the glare that's associated with the heat, regulating activity can be helpful in that context. But certainly when you get to 44-degree days in summer, there's a degree of heat that you just can't battle with. So again, sort of regulating your other activities in that context, I think, can be useful in trying to reduce the impact it has on your migraine.
Vicky had a question. She said that she was curious about what the signs would be if you're ready to try and come off medication for chronic migraine, so a preventive once things are stable.
And it's something you need to kind of keep revisiting over time, because you don't want people yes, we want everyone to get stable on a preventer, but if you're cruising along with really no migraine attacks, then you shouldn't be on drugs if you don't need to be on drugs. The way I tend to think about that is probably threefold. One is how stable is stable. So if I've got someone who's had no migraines for 6 months, 12 months, then absolutely we should think about withdrawing it. If it's somebody who is still getting kind of migraines trickling through, and if they're okay as long as they don't do X, Y, and Z, then they're still vulnerable, and I'd be less keen to withdraw the medication. And the other aspects come down to how well tolerated is the medication. If it's a drug that they're tolerating really well, there's less impetus to stop it. And the other thing is what I call life forecast. So if I have a woman who's potentially coming up to perimenopausal years or is starting to have hormonal changes, or someone's about to move house or start a new job, in that context, I'm a bit less keen to reduce medication until you're on the other side of that potential sort of destabilizer, as it were.
One final sort of question I'd like to ask you is, in the comments during the presentation, there were a few people that said they'd tried sort of a lot of the drugs and treatments, and some people had said they'd tried all of them. For the person who still has chronic migraine, who has tried so many different treatments and is sort of losing hope, what message can you share with them? Is there a reason to look forward to the future?
I very much think that you shouldn't give up. I think there's always reason to hope. There are new drugs coming out, so there are certainly new windows opening. And, the CGRP drugs were game-changing for a lot of people, but there are a proportion of people who don't respond to those, who may respond to things like the PACAP agents that are coming through. The new neuromodulatory devices are quite exciting. The other aspect is it's sometimes worth having a bit of a general rethink and regroup on the diagnosis and whether there are other factors at play. So one thing we see a bit in the clinic is people who develop kind of neck problems over time, overactive muscles in the neck and pain generated from that. which can certainly feed into their migraine. Mood disorders, sleep, other medical problems, other causes of pain in the head and neck that can trigger migraine. Is there more than one headache phenotype is the other issue, because you can have migraine plus another sort of headache. And if you're not thinking about both of those conditions, then pain from one will tend to trigger your migraine too. So sometimes it's just worth a little bit of a clear the slate and start from scratch and actually take the history again, examine people again, revisit what they've tried, whether they've tried it for an adequate time and an adequate dose. Was there medication overuse at play? Sometimes it is worth revisiting things that you've tried in the past in a different context or in combinations. And, the exciting thing at the moment is that there are new therapies becoming available at a rate we haven't seen in the last 30 years, which is fantastic.
Yeah, excellent. It's a really exciting time. I think the fact that there's different dosages of the treatment, there's layering of treatments, combining treatments, timing of the treatment, there's a lot of variables that can go in even within the list that we have. So lots of reasons, I think, to hope. Thank you so much, Dr. Hutton. It was an absolutely fantastic presentation. We're going to be getting that recording up on the website because I know that people are going to be asking us, so we'll get that up as soon as we can. Tune in tomorrow. Tomorrow we have 2 sessions. One is going to be at 11 a.m. Australian Eastern Standard Time. That'll be about mental health and chronic pain with Professor Dawn Buse. She's our international expert coming in from the US and a world-leading expert in her own right in that field. And we're also going to have a 7:30 session with Dr. Michael Eller, who's been with us in the past and is an Australian headache specialist, talking about side effects of medications, which is what you voted for in the topic selection. So that'll be another popular topic. But thank you so much, everyone, for joining us tonight. A big round of applause, and thank you, Dr. Hutton. Wonderful presentation. We look forward to hearing from you again very soon.
Thanks very much, Carl. And thanks, everyone, for joining.